Could I invite the panel up? Hopefully everyone knows who they are. Krispin, Patrick, and Natalie. And I think, Mark, you're presenting the cases.
Thank you very much, everyone. Good afternoon. My name's Mark. I'm one of the advanced trainees here at the Royal Brisbane. This case is called He's Got This Bug with a Funny Name, because that's probably the phrase I heard most often with this case. And it's really a talk about a complex bacterial infection in a long-term stem cell transplant recipient. So our patient's Mr. JB. He's a 41-year-old man. He had CML and unfortunately a myeloid blast crisis that led to an allograft from his sibling in May of 2014. Despite relapsing at around day 100 post-transplant and being treated for that, he actually made it through this without too many major complications, the most serious of which is probably the chronic graft-versus-host disease that primarily affected his skin, affecting a significant part of his body, but also affected his eyes and mouth. This was managed with compassionate access ruxolitinib, for which he's been on for a little while now. In addition, he had some bronchiolitis and some transplant-associated thrombotic microangiopathy that mostly presented as renal dysfunction, which was not being sort of actively managed. He'd obviously had a couple of infectious complications throughout this history, including multiple previous bacterial bloodstream infections with pneumococcus, ESBL organisms, Clostridia and Streptomyces. But overall had sort of made through like a stormy period of his transplant without too many problems. He had a background also of some type 2 diabetes, some osteoporosis, and some other issues that were all being managed. Here are his medications, which includes an allergy to tazocin that I'm not going to go into the details because it becomes important later. But you can see he was on sort of the usual prophylactic antimicrobials we'd expect. He was on a dose of prednisolone that sort of alternated a little bit depending on how bad his skin was, but was on about 25 daily before this presentation, also on some IV or subcut IG, I should say. So JB first presented with a rash on his left lower limb. This was quite a mild rash. He saw his GP, he thought maybe he had cellulitis and was started on some clindamycin. That appeared to have some mild improvement, but unfortunately things recurred. In that way that people do, he mentioned, oh, I've been cleaning my pool recently. It was heavily algae contaminated. And that was just something that stuck with the admission note there. And at the time, the hematology team thought it's either cellulitis or perhaps a flare of his GVHD, but he wasn't too unwell. And they thought this will be a 24-hour admission. He'll go home the next day. He spiked a temperature, so obviously some blood cultures were collected. They came back with a gram-negative bacillus. And so he was started on meropenem, given that he's an immunosuppressed host and he has allergies to tazocin. We knew initially that it would probably be aminoglycoside resistant and ceftriaxone resistant, so life went on. By the 29th of the 1st, we'd identified Elizabeth Kingier Anopheles in the lab, and they had kindly come up with some sensitivities. Given that we have a funny bug and some funny resistance patterns, ID was consulted. We stopped by and said, look, probably this is going to be intrinsically resistant to carbapenems. So we came up with a cocktail of ciprofloxacin and Bactrim, both of which were delivered orally, given he was reasonably well. Unfortunately, he continued to have Elizabeth Kingier Anopheles isolated in his subsequent blood cultures. So due to the fact he was persistently blood culture positive, we added in doxycycline at 100 milligrams BD. We're still positive every single day for Elizabeth Kingier Anopheles up to now about just shy of a week at this stage. So we're starting to look for persistent foci of infections. And really clinically, the only thing to find is this rash on his leg, this area of maybe cellulitis. He's got a plan for a PET CT and a TTE to look for endocarditis or similar other problems. At this stage, we start to see resistance issues creeping in that the MICs for ciprofloxacin and doxycycline increase. And And so due to the fact that they're probably not contributing a lot to his therapy, we stop those agents and continue on cotrimoxazole. We had thought about adding in rifampicin, but unfortunately the ruxolitinib and rifampicin had a prohibitive interaction in that we decreased the exposure of that. And given the severity of his GVHD, that was felt to be an impossible combination. So we tried something else. We tried adding tigecycline and minocycline. The tigecycline was started at 50 BD and was planned to be up titrated to a treatment dose of 100 BD. And we also had minocycline 100 BD intravenously as well. Perhaps unsurprisingly, the tigecycline was poorly tolerated, and it also didn't seem to make a difference to his ongoing daily bacteremia. So we stopped the tigecycline at that stage. From there, we see ongoing issues with resistance, and we start to think about what alternate options we have at this stage. So we considered cafetericol, which was an option, and we considered tazocin as well, which had sort of a decent-ish MIC. Obviously, the major barrier to this was the allergy to tazocin. So we looked back at his history, we clarified his allergy status, and it seemed as though while he was unwell, having a blast crisis, he was being transfused and treated for febrile neutropenia. At that time, he became febrile and unwell. And so the antibiotics were assumed to be part of that. He was changed over to meropenem and managed for many years without exposure to beta-lactams through all his various infections. He did actually have some skin prick allergy testing a few years after that allergy, which returned a negative response to beta-lactams. But given he was quite heavily immunosuppressed at the time, it was difficult to interpret that in any confidence. So we did a tazocin challenge. We gave him a dose of tazocin, and that was great. It worked. So we added tazocin into his therapy, which included cotrimoxazole and minocycline at that stage. It was initially QID dosing. We reduced it to TDS with his renal function. So oddly enough, the day we added the tazocin in was the day that he finally failed to be bacteremic. So he'd been bacteremic for 20 days all up. We had looked really carefully, and I won't go into all the details of where we looked. We looked at his CPAP machine. We looked at everything that we possibly could for a source of this bacteremia. Along the way, because transplant patients always do this, he got COVID. He also had some increasing nodular opacities on his chest X-ray that was diagnosed as an invasive aspergillosis, given he had aspergillus on the sputum, and he also had CMV reactivation as well, so multiple infective complications. We treated him for 14 days of therapy from his first negative blood cultures, and we plan to do some surveillance blood cultures after this. Everything ended well until it didn't, unfortunately. I was in the ICU actually seeing another patient at the time when I heard at the back of my peripheral hearing, oh, there's this hematology patient. He's had a long admission with this funny bug. I can't say the name of it. And I felt this chill go down my spine. And it was John back in, oh, sorry, JB back in again. So this gentleman had actually presented, again, cutaneous symptoms primarily with sort of flank rash that spread rapidly down his leg. He was initially treated actually as a necrotizing fasciitis with those antibiotics. We actually went back to our tried and tested recipe of tazocin, cotrimoxazole, and minocycline, and due to a E-test shortage of tazocin, we've got a disc diffusion there that gave us a number of some kind. So we had him back on that, and actually, thankfully, that worked. He was bacteremic again on the 12th of the 3rd, but he clinically improved. He was off ionotropic support and out of ICU. We revisited the idea of a persistent focus. We scanned his leg looking for osteomyelitis or something similar. We did another transthoracic echo. And it was interesting to note that his now sputum isolated a small amount of scanty growth of Elizabethinia anopheles. But he seemed to be improving from a respiratory point of view since we started treating him with some voriconazole. We got him culture negative much quicker this time round. We completed 14 days of our combination therapy and then discharged him with oral cotrimoxazole and minocycline with the aim for considering about suppressive therapy for this gentleman. In terms of his outpatient progress, he developed an itchy rash over his skin. He became a sort of gray-blue color and had some blue sclera. This was biopsied and was felt to be a drug reaction, maybe secondary to the minocycline, though the voriconazole is also a potential culprit. We've stopped his minocycline, continued on some Bactrim, and changed the voriconazole to posaconazole. Since then, his skin's actually got better. He's no longer blue-grey in color quite everywhere. His renal function has got a bit worse, and his cotrimoxazole is now at a single dose that we intend to continue for a long while. I'm sure there are loads of questions for the panel. Two questions that I had, I guess, in Elizabeth King bloodstream infections, should we always use combination therapy, and are there any combinations that are better than any others? And with the benefit of retrospect, was there something we could have done differently to prevent his second admission with the bacteremia after a complicated one? Thank you very much.
Such easy questions. I mean, I'm actually going to talk about another case we had like this in a minute or two. So we've had a few of these really different. I mean, this is a terrible organism. It's intrinsically resistant to almost everything. And then whatever you treat it with, it becomes resistant quite easily. So I think, you know, again, it's all a bit anecdotal. The data is all very sketchy. But certainly our experience so far has been that in monotherapy, you tend to get resistance emerging quite quickly. So I think intuitively one would sense that combination therapy is a better way to go. I don't know, again, if that's really based on anything beyond intuition and best guess. And obviously all these patients have all the interactions and other complications and toxicities that make life complicated. But I think there's, you know, they're clearly complicated and it's a difficult bug to get rid of. So that would be my recommendation. I think you just have to cobble together the best regimen you can from, and all these susceptibility tests, they're not, you know, there's no real breakpoint criteria for this organism. You have to kind of best guess based on PK/PD, or you extrapolate it from other organisms. And it's a little bit of sort of tiger country, sort of, you know, doing the best you can, but it's fairly uncertain.
First of all, I was one of the main clinicians involved in this case, and it does remind me that every time I see a patient, I should assume that in a few months' time, Monica and Ola and all of the people I most respect in the profession will all be reviewing it with a microscope. So it's good. It was very complicated. There's just so much going on with the aspergillus and the COVID, and he actually, as a postscript, just to really make Mark and me feel terrible, came back in a month ago with another gram-negative bloodstream infection, and it was a UTI with a Klebsiella or something completely unrelated. But gee, I had about 2 hours of extreme sweatiness when I realised. I mean, one thing I've really felt with this guy is that just the huge human cost of these uncertain infections, where we have little knowledge about how things were going. We're pretty, I think, after the multiple rounds of antibiotic failure and persistent blood cultures out, so about day 13, I think it was, when I was involved, we're getting pretty gloomy about things and having some fairly complicated chats with him. One thing, having said that, was for the first episode, he remained incredibly well through the whole thing, like almost had he lived in Uganda and not had any blood cultures, no one would have known any better. But it does have a huge cost when we don't prognosticate well. And yeah, I mean, it was a bit whack-a-mole, really, wasn't it? We sort of just trying to find antibiotics that worked. Probably the big learning point for me is one of the most useful things would be Andrew Redmond's antibiotic allergy delabeling clinic. One thing I've often thought about this case is maybe, you know, in part of the workup for bone marrow transplant, or if you have an antibiotic allergy listed, you should probably go via the allergy clinic, because in fact it was the FERFI. The allergy was a blood transfusion reaction, not a allergy. And he was all over that as well when we actually asked him about it. He sort of said, yeah, I just don't think it was anything. I think it happened during a blood transfusion. So, but that meant it was sort of actually was a week of digging through notes from a different hospital that were still in handwritten form and things. So very hard to find that information. It's a good result though. I just saw him yesterday actually, and he's looking great, going really well. So. Yeah.
I think the only other thing I would say from a lab perspective is when we get these tricky bugs and we don't really know what we're doing with susceptibility testing, as Patrick said, I think it's important for us to really have the communication with you guys in the clinical team. And we really did well with this case. And, you know, all we can say is this is what we've got. If they're not doing well, you know, give us a call and we'll really try and think of some other things. And we did do some Keftas-Aviaz Tri-M disc strip testing kind of offline, and which, you know, didn't demonstrate any synergy for this patient, but we can kind of think out of the box a little bit. So I think that really helped in this patient's case. And I was going to ask you, Mark, did you find a point environmental source for this guy, since you didn't find a source within?
Not really at all. Like the thing that's very striking is this sort of environmental exposure before all this started, but like there's nothing convincing. We looked very carefully at sort of his home environment, at his paraphernalia by the bedside, and we just never found anything that was very convincing as to where it originally came from.
Just mindful of time, but can I push you guys a little bit on the second point? Because I too was also involved in this case, and he was profoundly immune suppressed. Okay. And I know we had some debate about the duration of therapy and how long to go.
Can I just say, I'd rotated off the ward by then. So I would have done the other thing that didn't lead him to be readmitted, but I don't know what that is. Oh, I don't know. It's tricky, isn't it? It's very hard to tell. I don't know. I probably wouldn't have done much different, but I'm very our invited experts.
Thanks. I don't know that I've had any great experience with this bug. I've seen it a couple of times, and where I've seen it is usually people who are highly immunocompromised and have had quite a lot of antibiotic exposure already. And it's one of those bugs I think about in that scenario, a bit like Stenotrophomonas and Elizabeth King-Ellie. They just pop into your brain in that highly immunosuppressed patient who's had a lot of antibiotics. But I don't have a recipe for treating it. And yeah, I think you just do the best you can like you did, basically. I haven't really got much to add.
Just a quick one from a lab perspective, the MIC against fluoroquinolones, I think it was, I'm guessing ciprofloxacin, was fairly low. It was around 4, where you classified as resistance. Do you think that's significant?
Yeah, I think you're right. It's not high level resistance. You might well be able to achieve, particularly with therapeutic. In fact, there's a case again I'll talk about in a minute where we did a lot of therapeutic drug monitoring. So I think, these SNRs, they're really calibrated against the sort of worst case scenario and standard dosing and other factors. So if you've got the ability and no other options, and you can give high dose intravenous Cipro and you've got nothing else, and you might combine it with another drug, it's certainly an option. So SNR, it's a probabilistic game. It's sort of saying this MRC is higher than we would like it to be. It's going to be hard to achieve proper exposures, but it doesn't mean you are guaranteed failure. Plus, there's a bit of, there's a margin of error. As you can see, you can test it 2 or 3 times. The MIC might flip a few dilutions either way. So, when you're in a tight corner, all bets are off. And it's not standardized breakpoint. So that's not saying this is a very well validated answer. It's the best we can do.
You should sequence the strain if you've got it, because it'd be interesting to see if it has the traditional mechanisms of resistance, and I'd be guessing not.
Yes.
You should just do Illumina.
One of the things I had thought about is, although I guess there may be environmental sources, I had wondered if it had come from his gut, and had he had a FMT before the current round, it might not have been there because it might have been dislodged, or at least we might have metagenomically identified his microbiome and been able to anticipate all of this. Things like, practically speaking, getting clofidogrel from compassionate access takes a while. For example, if it's all possible, having a game plan before all this happened would have been handy.
Just to add a little technical thing, the clofidogrel DIS was 16. Now we know actually DIS testing for clofidogrel, particularly for non-fermenters, is not very reliable. And there's a UCAS warning saying that, particularly for Acinetobacter, don't really believe the DIS at all. We don't yet have MICs available. The broth and clofidogrel testing base is a nightmare. No one really quite knows how to do it properly yet. So again, if you were really, really desperate and you had clofidogrel, there was a zone, and I'm not even too sure. In theory, it may be effective, but again, who knows?
Any other questions? Otherwise, I'm sorry we ran over time a little bit. It's time for a little bit of afternoon tea, I think, before the afternoon session. If I could thank our panelists, thank all of our presenters. I think it's been a really informative session. So thank you, and we'll have a quick break.